Hey, Jeff Nelson here. Welcome back to the channel. Today, we have an incredibly insightful session lined up with none other than Dr. Peter Rogers. Welcome, Dr. Rogers.
Hey,
Great to have you, always. So
thanks.
after being educated at places like Stanford and Harvard, where he was always at the top of his class because he's a genius, Dr. Rogers has been a practicing physician for over 30 years, and he's a passionate advocate for plant-based diets. He's got a knack for breaking down complex medical concepts into easier to understand language, and his experience in radiology gives him a very, well, I would say, unique perspective on health issues that so many people face today. Dr. Rogers' journey from a general radiology to his passion for neuroradiology shows that he's committed to exploring the intricacies of the human body, particularly the brain, which he finds the most fascinating. In his talk today, Dr. Rogers will explore what he calls Western abdomen diseases. He's going to explain how our typical Western diet is wreaking havoc on our bodies. Well, maybe not our bodies, but on the bodies of millions or hundreds of millions of people who haven't figured this out yet. And that diet is causing everything from fatty liver and kidney stones to more severe conditions like diabetes and heart disease. But it's not all doom and gloom. Dr. Rogers is also going to share how you can turn around with some, relatively simple dietary changes. So get ready for a deep dive into the science behind these conditions, along with very practical advice on how to prevent and reverse many of them. So this is an opportunity to learn from a leading expert and gain valuable knowledge to improve your well-being. So with that, Dr. Rogers, how's life?
How's life treating me like a baby treats a diaper? Things are going all right.
All right. What is your day generally like in your medical life there? Do you see a lot of patients?
Yeah, well, my day has kind of changed once I started out. I did a surgical internship, then I did a radiology residency with the emphasis on interventional. I did interventional fellowship, and I was an imaging guided surgeon, interventional radiologist for many years, and I gradually switched to becoming primarily a neuroradiologist. So my interventional days, I make rounds on all my patients, do a bunch of procedures, that sort of thing. I was basically a surgeon. And then as a neuroradiologist now, I crank through lots of brain MRIs, and I do a lot of consultant work in the sense that lots of people come to get my opinion. I teach all the other doctors about the brain and about brain diseases, brain anatomy and whatnot. And I enjoy it. I find the brain fascinating. So
That's great. Now, I also know from watching your many videos that your Spartan vegan diet, as you call it, although you may have changed the name from time to time, you also practice OMAD, one meal a day. Is that right? What time do you eat?
It's because it's convenient. One meal a day. I just eat a dinner when I go home. So I eat a big plant-based meal, and it works for me. I think the beans might be the most effective thing in terms of keeping your hunger satisfied. But if you look at diagrams of glycogen, along with gluconeogenesis in the liver, can typically maintain a good blood sugar for at least 2 days. So what I'm saying is it's easy to do it. Some people say, oh, I'll be hungry if I wait 24 hours between meals. I do it all the time, and I never have a second thought about it. Oh, I do have one little trick. Sometimes if I get a little tired, like I didn't get enough sleep the night before, I got tons of work still to do, I'll guzzle down 32 ounces of beet juice, chase it with about 10 ounces of water, and it gives me the same effect that caffeine would, but it doesn't interfere with my sleep at night. There's no caffeine component. I don't know if it's maybe the hydration, elevation of blood sugar, but when I'm tired, I found that's a great way, because sometimes I'm up late, I don't sleep as much as I should. I also do that before my workouts. I do that before I give a lecture if it's going to be an hour or longer. I know it energizes me. I do it before, I'm lifting weights. So if I'm going for a personal best, high rep squats or something, it's a good energizer without the caffeine effect.
That's great. So now when you eat dinner, do you get, consciously, do you try and get really full? Are you stuffed at the end of dinner? How does that work?
Well, I typically, ideally, if I was trying to lose weight, I would start out with the veggies, low caloric density, kind of the Chef AJ school of weight loss.
Right.
But my weight's pretty good right now, so I don't even think about it. And I usually sort of dive right into the starches. Typically something like organic white rice with some beans and then some potatoes or sweet potatoes. That would be the most common starches that I eat. My favorite fruit is blueberries. Sometimes I'll have watermelons. You got to be a little careful how much you eat of those at night, though, because they're very heavy in fluid. And you're going to be waking up the void more if you eat too much of that. And then I always try to have at least one salad. If there's anything else cooked for me, I'll have that as well, but kind of depends what's available. If I'm eating a lunch, which I don't too often, plain oatmeal with water or quinoa are good. I put blueberries in them and whatnot. Those are good starches. They're pretty wet foods, though. Again, I don't like to eat too wet of a food before I'm going to bed at night.
Yeah, I get that for sure. Well, I know there's a lot to cover. Why don't you get to work and start your presentation, Dr. Rogers?
Okay, well, thank you. All right, here we go. Okay, so the first picture here is basically Dennis Burkitt's abdominal pressure syndrome. So Dennis Burkitt was an Irish Christian missionary surgeon who went to Africa. Okay, and he became famous for discovering the pattern of a disease called Burkitt's lymphoma. It was named after him. And then he became in charge of epidemiology, all Africa, and he studied all the patterns of disease. And what he noticed was the person who's eating a plant-based diet, which was most of the persons in Africa at that time, they never got the common abdominal diseases, whereas his colleagues, from England or Ireland, they had tons of this stuff, the same as they did back in England and Ireland, because they're eating a westernized diet. So what's the point? When you eat fiber, it pulls water into the stool. So the stool is liquefied on the right side of the abdomen. And when you defecate, it's like a cow patty, okay? Versus a typical Westerner eats a very low fiber diet. Burkitt believes we should eat about 100 or more grams of fiber per day, at a minimum about 50. Average American's eating about 10 grams per day. So they're relatively constipated. Their stool's relatively dry. When they defecate, it's typically goat pellets or Tootsie Rolls. Okay, and they strain a little bit defecation, tightening the abdominal muscles. That's called Valsalva maneuver. And the Valsalva maneuver, back pressure, is transmitted into the chest. Okay, well, first of all, one last thing about the dry stool. When the stool is dry on the right side of the abdomen over here, they'll form little dry stool balls. Lith means stone. Appendix hangs off the cecum, the lower part of the right colon, like a pinky finger. Okay, so what happens is you form an appendical lith. Appendal because it's location, lith meaning stone. So it's also called a fecalith. It's a stool ball, a rock of stool, and it blocks the passage of the mucus glands to reach the cecum. So what happens is it's obstructed. The mucus glands keep secreting, but they can't get past the appendical lith, so it pops. That's appendicitis. Okay. So in the past, I used to have to drain a lot of abscesses for perforated appendicitis. Meat eaters, processed food eaters, Westerners get way more appendicitis than people eating plant-based diets. Okay, then the stool goes around the colon and it comes out through the rectum, of course. And when a person's constipated on a routine daily basis, that back pressure from the Valsalva maneuver of straining at defecation, they get hemorrhoids, so they're more likely to have blood on the toilet paper when they wipe. They get back pressure into the sigmoid colon, which causes outpouchings of the muscular layer, and that's called diverticulosis. Okay, I see that all the time. I expect a patient in a Western country to have more than over 50 years of age to have diverticulosis. Most of them do. Sometimes those diverticuli will pop from the back pressure and they spill stool into the adjacent abdomen, into the adjacent mesenteric fat, the visceral fat, and they get diverticulitis. When you see itis, that means something is inflamed. Diverticulitis is very common. Every hospital in the Western world is going to admit, one patient, at least one patient a week with diverticulitis and with appendicitis. So what happens then is sometimes I'll show you a picture of that on a CAT scan, what it looks like. Real quick, we'll go through abdominal pressure syndrome. Increased pressure, straining at the stool, causes hernias to pop out of the abdomen. That's like inguinal hernia right there in the groin. I didn't draw it on here because it'd be too crowded, but right around the belly button, that's a periumbilical hernia. The upper stomach gets pushed into the chest, and that's through the esophageal hiatus. So that's called a hiatal hernia. Then they get gastroesophageal reflux, GERD, G-E-R-D, gastroesophageal reflux, super common. You get heartburn discomfort, is typically called, nausea, increases the risk for esophageal cancer down the road. As a matter of fact, when I started out, main type of cancer in esophagus was smoker drinker cancer, squamous cell. Now it's an adenocarcinoma from reflux. You get back pressure down into the leg, and the back pressure down into the leg causes varicose veins. So women find that interesting. You tell them that. There's the big secret. The other thing, too, is because you're constipated, the back pressure is transmitted down into the scrotum. So you get dilation of the veins in the scrotum, and that's called a varicocele. And it heats up the testicles, and that can cause infertility. So constipation can cause infertility. It contributes to it. Okay, so that's the main gist of abdominal pressure syndrome as described by Burkitt. You also get more gallstones, and that's simply because you're eating a real high-fat diet. The higher the blood cholesterol, the higher the cholesterol is going to be in the bile, and it's more likely to precipitate out. 95% of gallstones are cholesterol gallstones. So that is abdominal pressure syndrome as described by Burkitt. Now here is a CAT scan, transverse sections through the pelvis. You can tell you're in the pelvis. You can see the pelvis bones here. Here is a sigmoid colon, and these little bubble outpouchings from the sigmoid colon are diverticulosis. And then here you see the fat is all messy and dirty. Normal fat is relatively clean. Like, look at this fat here, subcutaneous fat. By the way, this is subcutaneous fat underneath the skin. Sub meaning beneath, cutaneous skin, subcutaneous fat. Okay, and here is the visceral fat beneath the anterior abdominal wall. All right, so normally mesenteric, it's called mesenteric fat. Normally the mesenteric fat's pretty clean. This is all dirty with inflammatory stranding because a diverticulum has perforated and is leaking stool into the abdomen. I knew a guy from a country where they eat real high fiber diets, and he told me, in my country, we don't have any diverticulosis. You could look at 100 CAT scans, you won't see any diverticulosis. He was a radiologist from a real high fiber eating country. All right, anyway, so here's diverticulitis. Most of the time, they can treat them with antibiotics and they get better. Sometimes, though, there'll be an abscess. I got to drain the abscess. I used to do a lot of abscess drainages with CAT scan guided, placement of percutaneous catheter drainage. And then if it was really bad, let's say there's a perf with a large amount of free air in the abdomen, they'd have to go to open surgery, sigmoidectomy and a diverting colostomy. Okay, here is a Dennis Burkitt biography. I've read a couple of his books. They're good. This is my favorite book about him by Ethel Nelson, MD, Burkitt Cancer Fiber. And it talks all about his travels and how he figured everything out and stuff. Yeah, he was great. He was a very impressive man. He, another guy who deserves a Nobel Prize, but I'll never get it. He's not even in the books. That's kind of it is. All the pioneers in nutrition, they're not even in the books. They don't want the trainees to know about them. Okay, here's Dennis Burkitt quote. The only way we are going to reduce the frequency of these diseases is to go back to the diet of our ancestors. And he's absolutely right, because these are dietary diseases. You cannot cure a dietary disease with a pill or a surgery, okay? And so no medical surgical BS is going to change that. That's just reality. Okay, here's another picture. Oh, this is just pointing out some of the fat issues. The liver, a high-fat diet is going to cause fatty liver typically over time. I can tell you, I see fatty liver so often that I now expect it. The majority of patients over 50 have fatty liver. I'd probably say the majority over 45 have it. I haven't checked at 40, but it might be at 40 as well. I see it all day long, all the time. And it's associated with all these other conditions. They all go together. Typically, you'll start accumulating fat in the skeletal muscle first. That's what initially causes insulin resistance, causes diabetes, and that will cause prolonged elevated blood sugar after eating. Prandial is to eat, so that will cause postprandial hyperglycemia. When you start accumulating more fat in the liver loses its ability to accurately sense the blood glucose level, and it's the job of the liver. The main thing the liver does is make sure the brain has enough glucose. So the liver has to be good at sensing blood glucose. When it's all fatty, it becomes dysfunctional, and it tends to misgauge the blood glucose concentration. So it keeps on releasing more glucose into the liver from gluconeogenesis, for example, and the breakdown of glycogen, glycogenolysis. So you get prolonged elevated blood glucose even during the fasting. So muscle is postprandial hyperglycemia. When you have fatty liver, now you're going to have fasting hyperglycemia. Eventually, the prolonged, decades of hyperlipidemia, elevated blood fat causes increased fat to accumulate in the pancreas, and you start getting a fatty pancreas. You'll also get the elevated blood lipids are also toxic to the beta cells of the pancreas that make insulin, so you will then get fatty atrophy of the pancreas. I see that all the time on a CAT scan. Fatty atrophic pancreas, patients got diabetes. Okay, so this is, and also this has a name for it. There's a guy by the name of Gerald Shulman, 2012 Banting Award winner, best diabetes researcher in the whole world, and he calls it the ectopic fat theory, meaning that we tolerate subcutaneous fat pretty well underneath our skin. When we start getting more visceral fat, we're trending into, fat accumulation in the skeletal muscle, fat accumulation in the liver, and subsequently fat accumulation in the pancreas. And again, the same patients are going to very often have gallstones because these are all high-fat diseases, okay? And the same patients, by the way, they're going to have calcifications of their coronary arteries routinely. All these diseases go together. That's a key point of this talk. And that's actually going to be one of the secrets how you can improve your health. Okay, so here's a typical CAT scan of a fatty liver. Normally, the liver should be denser than the spleen. CAT scan is all based on densities. The patient basically sits on a table, and this rotating camera goes around him. A radiation beam goes through him, a detector's on the other side, and it measures the density. So normally, the liver should be denser than the spleen. Here you can see this liver is less dense than the spleen. By the way, the liver is giant. It's like the biggest organ in the body, the biggest single organ in the body. And these HUs are Hounsfield units. Hounsfield is the name of one of the inventors of CAT scan. Okay. And also, if you have less than 40 Hounsfield units, that's a fatty liver. So this meets it by both criteria. This is a fatty liver. Okay. Now here's how you diagnose a fatty liver by ultrasound. And this is the most common way it's diagnosed. You can see that the liver is hyperechoic, meaning more sound is reflecting off of it compared to the kidney. This is the kidney right here, the kidney cortical parenchyma. Cortical means outside, outer part, it means bark, like the bark of a tree, of a tree stump. Okay, so you see the cortical parenchyma is relatively echolucent compared to the liver. More sound is reflecting off the fat in the liver. Okay, so typically, like if a patient will have elevated liver function tests, elevated LFTs, you don't even need to look at the chart. The patient has fatty liver. I can tell you 99% of the time or more, they'll have a fatty liver if you get that history, elevated LFTs with no other information. Okay, so real quick, let's just look at how the liver is connected to the spleen. The main vein going into the liver from the intestinal tract is superior mesenteric vein. Blood then goes up through the portal vein into the liver. So that's important. Remember, the portal connects the gut to the liver. Okay. But one thing people seldom think about is the portal vein is also connected to the splenic vein, the outflow from the spleen. And what this means is when you get elevated back pressure due to liver failure, fibrosis, cirrhosis, you're going to have back pressure on the spleen, and that's going to become relevant. Okay, and you can then see, we absorb food, goes into the mesenteric vein, up into the liver. That's what normally happens. Okay, so the point that I was going to make is when you get progressive disease of the liver, and you can get that from fatty liver can progress to steatohepatitis, and that can progress to fibrosis and cirrhosis. Okay, I'll show a better picture of it in just a moment, but that back pressure can make the spleen get big. A big spleen can develop what's called hypersplenism. It can start chewing up red blood cells and you become anemic. It can start chewing up your platelets and you become low in platelets, thrombocytopenic, and the low platelets predispose a person to bleeding. I had a guy not that long ago with fatty liver, progressed to steatohepatitis, to fibrosis, to splenomegaly, chewed up his platelets, fell down, hit his head, he had intracranial bleed. Now that's really rare, but that's sort of the end stage of all this stuff. It used to be that cirrhosis was almost always, alcoholics and hepatitis patients and a couple rare other causes, but those were by far the most common ones. Nowadays, it's very common that it comes out of this fatty liver progressing. So they call it NAFL, non-alcoholic fatty liver. And then the progressive step is to NASH, non-alcoholic steatohepatitis. And whenever you hear itis, you hear inflammation. As soon as you hear inflammation, you should think that the immune system comes in to clean up and puts down a bunch of collagen, fibrosis. So inflammation will have a tendency to progress to fibrosis. And fibrosis of the liver, when extensive, is cirrhosis. Okay. All right, so this was just sort of, a review of that ectopic fat theory of Gerald Shulman. And I actually wrote out a staging system for this, but it's pretty basic. Skeletal muscle first, postprandial hyperglycemia. Subsequently, fatty liver and fasting hyperglycemia. Subsequently, destruction of the pancreatic beta cells. It causes problem with protein folding. You can't make insulin fold correctly. And then you get failure of the beta cells. And the problem with that is once you've lost that ability to make insulin, now the patient will become an insulin-dependent diabetic. And they get all these complications. We won't go into all this stuff right now, but it's not good. You don't want this. Oh, one thing I show you is here's a picture of Prometheus, the ancient Greek god, the one who climbed Mount Olympus to steal fire from the Olympian gods and give it to mankind. Okay, Prometheus was our friend. And the reason I'm showing you this picture is, Zeus got mad at him for stealing fire, and he tied him to a rock, and he had an eagle eat his liver every day. The point of this picture is that, by the way, Hercules saved him by slaying the eagle. So anyways, the point of the picture is the liver renews itself. So the good news is if you got fatty liver or you got another liver problem and you get your act together for your health, there's a good chance the liver will fix itself. It sort of grows back. It's kind of an amazing thing. Okay, now here's the progression of steps, and this is really useful to know because this same similar sequence of events occurs in other parts of the body. So you start out with a normal liver, and then you're eating way too much fat, drinking too much alcohol, too much high fructose corn syrup, too much of a high fat diet, and you get NAFL, non-alcohol fatty liver. Because again, alcohol used to be the most common cause of fatty liver. Now it's most commonly from high fat diets, non-alcohol fatty liver. And that can progress to NASH, which is almost the same, non-alcohol in the first two letters, and then steatohepatitis. So steato means fat, and hepatitis means, hep means liver, itis means inflammation. So now it's progressing from just being a fatty liver to an inflamed fatty liver. And these little drawings here are sort of the prelude into cirrhosis. The fibrosis becomes more extensive, and now it's called cirrhosis, which is sort of like advanced fibrosis of the liver. The problem is when you lay down all this collagen, fibrotic tissue is typically collagen. It starts contracting and squeezing things and walling things off. And you're going to have cells. Imagine that this green marker was a normal liver cell. It's going to get trapped in all the collagen wrapping around it. And the point of that is this normal liver cell, it wants to live and it can't get enough oxygen. All right. So what happens when it can't get enough oxygen? It becomes dysfunctional. If that goes on too long, it'll die. But sometimes the cell will transform itself. This is called the Warburg effect of Otto Warburg, 1931 Nobel Prize winner. The cell will revert to a primitive pathway of anaerobic glycolysis. Glycolysis runs in the cytoplasm. The mitochondria is a separate organelle that requires oxygen for producing ATP, the energy of the cell. So what I'm saying is, when the world was first formed, there was no oxygen, and then oxygen gradually became available, and it would be intermittent, it is thought, and a cell might have to revert back to anaerobic metabolism, which just means glycolysis. So what I'm saying is, it is thought that cells somehow, sometimes will have the ability to revert back to a primitive pathway of running their energy system off of anaerobic glycolysis. They'll have much less energy, but sometimes a cell can survive. And that is thought what happens in cancer. So what I just described for you was the metabolic theory of cancer based on the Warburg effect. So Warburg effect is mitochondrial injury due to hypoxia, typically, with the cell transforming into a cancer cell by running primarily on anaerobic glycolysis. And fibrosis can wall off normal cells and thus diminish their oxygen supply and have them undergo Warburg effect and become cancer. And that's really important because you'll see how this happens in other locations. Here it is in the lung. You inhale asbestos fibers, okay? Let's say you're insulating ships or something, all right? And they used to put asbestos fibers in other places, in buildings, for example. The asbestos fiber is inhaled into the lung. It causes an inflammatory response. Fibrosis forms around it, the gray material here, and then some normal lung cells get trapped in there. They become hypoxic. Some of them will potentially transform by the Warburg effect and become cancer. Okay, so there it is again. Inflammation, fibrosis, hypoxia, cancer by the Warburg effect. And that's the metabolic theory of cancer. I think the metabolic theory of cancer is much more useful than the SMT, somatic mutation theory, because all the books go by somatic mutation theory, that some type of mutagen, DNA damaging chemical causes a mutation in the DNA, and then that leads to the cell replicating abnormal and becoming cancer. But if you look at the Cancer Genome Atlas project, it really didn't go with that. In my opinion, it largely disproved it. So I think the somatic mutation theory plays a role in some situations, but the metabolic theory of cancer makes much more sense. And it makes sense, and it correlates with the T. Colin Campbell findings about protein and animal protein have more. We're not going to get into all that right now, but all I'm trying to say is I think T. Colin Campbell was correct in his findings on cancer and protein, and there's good reasons for that. That's a topic for another day, but I'm just letting you know it all fits together and makes sense. And the great thing about the metabolic theory of cancer is that it tells you what to do. You avoid the things that lead to tissue hypoxia, and then you got a good chance to markedly lower your risk of cancer. And there's reasons to believe you can markedly improve the prognosis, but we're not going to get into that today. Okay, so here's just one little quick summary of what a cancer cell does. Regular anaerobic bacteria, it just wants to replicate. Bacteria are real simple. They just want to replicate, make copies of themselves, and then they die. Eventually die. Okay, a normal human cell, most cells in our body are workers. They just work all the time. And so they need lots of ATP energy to do their job. A liver cell has to detoxify things, maintain blood glucose levels, manage the glycogen, manage gluconeogenesis, etc. Whereas the cancer cell is like a bacteria. It just wants to replicate. So this would be a cancer cell. And by the way, that's why it's going to take in so much more glucose, about 100 times more than a regular cell. That's why it's positive on a PET scan, fluorodeoxyglucose PET scan, because it's taken up 100 times more glucose than a normal cell. And then, we talked about the Warburg effect. So I'm just making that point. And why am I doing it? We're going to talk about how this relates to the pancreas in just a moment. Okay, we've talked previously about how red blood cells typically about 7 microns. That number is worth knowing, 7 microns. Typical capillary is only about 5 microns. So the point of it is the red blood cell has to fold back on itself. You can see it folding back on itself to pass through a capillary. Now, if you make the red blood cells all stick together, like by eating high-fat meals or eating things that cause a lot of uric acid in the blood, excessive psychological stress, and there's a few other things that stick red cells together are called bridging molecules. Now the red blood cells are all stuck together like a submarine sandwich, and it's harder to push them through the capillary. The blood has become thick. The medical word for thick blood is increased viscosity. And remember, the purpose of a blood pressure is to pump blood to the top of your head, your cerebral cortex. You have to pump all that blood against gravity and deliver oxygen to your brain tissue. And so basically, if you have to pump thick blood, pressure has to go up. You have to pump at a higher pressure with a milkshake than you do with water. Normal blood's like a water. After a high-fat meal or with other bridging molecules in the blood, it becomes like a milkshake. Pressure has to go up. And then chronic pressure over time damages the artery, causes more atherosclerosis, and you get into a vicious cycle. Okay, this is just an example of the spleen. I'm showing you what the spleen does. The spleen is like a filter for blood. And basically, when blood cells are young, they're really flexible. They typically live 120 days. That's about 3 months. Okay, and they normally can deform pretty well, and they go right through the spleen. Typical capillary in the body, about 5 microns in diameter. Spleen has these sinusoidal capillaries that are only about 3 microns. So the red blood cell, it's like doing the limbo. It has to be real flexible to get through the spleen. Otherwise, it gets removed by those tight capillaries, and the spleen has a lot of macrophages to remove them. So what I'm saying is, if you have liver failure with back pressure causing the spleen to enlarge, it starts taking more red blood cells and platelets out of the system for this reason, okay? So here's what I meant. Here's the portal vein. If the liver gets fibrotic, there's more resistance to inflow of portal vein blood. So back pressure is transmitted. This is called portal hypertension. It's a finding characteristic of cirrhosis. Back pressure is transmitted to the spleen, and the back pressure of the spleen causes it to swell up, and it starts sucking out more red blood cells and platelets. So that's what that whole hypersplenism was about. And now I wanted to talk about this, Western diet. When I say Western diet, I mean the SAD diet, standard American diet, which is a diet with a lot of animal foods, a lot of meats, which are high in saturated fat. And it also typically includes a lot of oils for cooking with oils, frying foods. And so now here's clearly a fatty liver. You can say this is a CAT scan. This liver is much less dense than the spleen over here. And you can see normally the pancreas looks more like this, relatively solid of intermediate density. And you can see there's all these low density areas in the body of the pancreas, the neck of the pancreas. This is moderate amount of fatty atrophy of the pancreas. Okay, so this is an indicator that you're losing beta cells, the cells that produce insulin. All right, and as this occurs, you will start out with, they've got the terms here, non-alcoholic FP, NAFP, non-alcoholic fatty pancreas. All right, and then you're going to get NASP. Does this sound familiar? Non-alcoholic steatopancreatitis, meaning that the pancreas starts becoming inflamed. You'll develop problems within the individual cells, like you'll have the abnormal folding of the insulin as it's made, because normally when you make a protein, it has to fold correctly. And when they accumulate a lot of fat inside of them, the pancreatic cells have trouble folding the insulin. And non-alcoholic steatopancreatitis can progress to death of the pancreatic cells, fatty atrophy, fibrosis of the pancreas, and that fibrosis can then cause some cells to be hypoxic, and hypoxic cells usually die, but sometimes they can transform and become like an anaerobic bacteria, and you can get pancreas cancer. Now, pancreas cancer is not that common, but it does occur significant enough, and and it's a bad cancer. Most of those patients die, and they often die pretty fast. But like I'm saying, there's some reason to believe, again, if they did the same thing, avoided the things that cause tissue hypoxia and tissue acidosis, that there's reason to believe that they could have better outcomes. But what I wanted to show you is this pattern of the metabolic theory of cancer, this progression from fat accumulation, inflammation, fibrosis, ischemia, hypoxia, Warburg effect, transformation of a cell, cancer. So this is another reason why vegetarians, I know there's a whole bunch of stuff, and I'm not getting into all the cancer pathophysiology today, but I just want you to understand the gist of the metabolic theory of cancer because it's useful to know that. Okay, here's the slide again. We're going to talk about, okay, here's a spine, which makes me think I'm going to talk about spine now. I think that's my clue. All right, and there's a little bit of scoliosis, meaning that there's curvature of the spine, and it's convex towards the right. You can always tell what's right and left because it's like, imagine you walk into a room and you see the case. It's as if the patient's feet are towards you. So this would be the guy's right foot towards me and the left foot towards me, and he was laying on a CAT scan table. All right. So the point of the scoliosis, this is not a teenage girl in your junior high class wearing a brace. This is a different type of scoliosis. This is what's called degenerative scoliosis. And you can see at this disc space level, it's more narrow on the patient's left side, and it's almost normal on the right side. So what I think of when I see this is that the lumbar artery, so lumbar arteries come off the abdominal aorta. I think that the lumbar artery on this side, the left side, has atherosclerosis in it. So it's narrowed. Narrowing in medicine, the term is stenosis, or it's occluded. Okay, so that the left side of the disc has failed, and as it fails, it'll lose disc space height. And so you can get asymmetric disc space narrowing, and over time that can lead to degenerative disc disease. And as the disc space narrowing gets more severe, you get a vacuum effect, gaseous disc degeneration, as we have here and here, and the disc will you get bone on bone, and they'll erode into each other. Those are called Schmorl's nodes, degenerative disc disease related erosions. Anyways, they lead to degenerative scoliosis. Okay, I'll go into that more and explain that a little bit more. And I'll talk about the other things on here as well. Okay, one thing too we see all the time in the modern Western and abdomen is a big fat belly. This is a typical guy, and a typical guy is actually not that embarrassed about it. He said he thinks it's actually macho. Typical guy will say, "Oh, I've got a beer belly," and my opinion is that's really pretty stupid. To me, you look like a pregnant female. It's a bad look. There's nothing good about it. You're accumulating a lot of estrogen, and they often have moobs. Moobs is the word for man boobs. And if you look at them under a CAT scan, you'll often see there's increased development of breast tissue there, ductal breast cells. So that the word for that is gynecomastia. That means like a woman. You don't want that, okay? And they sometimes also call it the apple-shaped body type. Okay, and then there was this lady named Jane Ansbaugh. She wrote a clever book about Walter Kempner, MD's, fat clinics out in Durham, North Carolina. And she talked about being fat. She said being fat was like having the letter F on your belly, the fat scarlet letter. Wherever you go, it was noticed. So I thought that was a little funny. But nowadays, there's so many fat people, it's common to be fat. Nowadays, it's high status to be skinny. It's uncommon. Okay, now here's just a good demographic population comparison. If you go back to northern Mexico, in the Copper Canyon area, you've got the Tarahumara population, and they still eat their old-fashioned diet. You know, a lot of corn and beans and local greens, and they're real skinny. Okay, they're real famous for running over 100 miles in 2 days, and it's like every guy in town can do that. It's not like the fast guy, all right? And then the Pima were a population adjacent to the Tarahumara, but they got separated in the Mexican-American War, 1848, and absorbed into Arizona. And they now eat the standard American diet. And they're off the charts sick with all the Western diseases. Obesity, diabetes, hypertension. Those are sort of like the gateway diseases. And then all this other stuff. Coronary artery disease, so he's got a cabbage. Coronary artery bypass graft surgery. They get diverticulitis, appendicitis, gallstones, diabetes, lower extremity amputations, off the charts. Okay, so I said you can either end up with total body ischemia from eating a fat diet, or you can end up with total body energy from eating a plant-based diet. I mean, once you understand, only an idiot would go down this path. I mean, I'm sorry, but it's like, once you know it, it's pretty obvious. Okay, Scott Jurek is this famous ultramarathoner guy. He went out there to train with the Tarahumaras, and other people have gone out there. Ruth Heydrich, the famous triathlon champion who's been alive after metastatic breast cancer diagnosis over 45 years, she went out and trained with him too. And this guy, Chris McDougall, I don't think he's related to Dr. John McDougall, but this guy, Chris McDougall, wrote a very good book about the Tarahumara runners called Born to Run. And Scott Jurek wrote about a book about them also. So they're for real. They're pretty interesting. Now, here's a picture of the Pima back in the 1800s. And the Pima, look at these guys, how fit they are. Okay, they look like a college wrestling team. Okay, now they're a bunch of fatzos. Okay, diet makes a big difference. You know, it used to be just diet, but I'm going to say in the modern world, you also want to know about toxicology, because there's more and more toxins in the food supply, in the air, in the tap water. So, it's worth your while to know about them. And basically I say, you're starting out here. Imagine this is the map. Okay. You are here. Let's say you're middle age. It's hard to talk to a young person. Young guys think they know everything. You can't tell them anything. And they're pretty healthy because they got a lot of physiological reserve at that age. But they start hitting middle age, having to commute to a job far away so they can live with the kid in the suburbs next to, their mother-in-law. And then they're tired. They're working a lot. They're not getting enough sleep. They start getting fat. They have a baby. They're up at night getting less sleep. All of a sudden, they're fat. And it's like, hey, what happened? All right. And so what will typically happen, what the typical person does, they don't know any better. They go to a conventional doc who's not trained in nutrition, epidemiology, toxicology. The three most important things. Doctors aren't trained in those things. Okay. And so all they know is drugs. So they put them on drug after drug after drug. The drugs fail, chop, 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 surgery, bye-bye money, prematurely dead. That's the typical American's life. Most people I see by 60 years of age are cognitively slow. By the way, I'm 60 years of age. I have no medical problems. I don't take any pills. I'm strong. I can concentrate all day. I see 20-year-olds nowadays that are having trouble with their memory and all these other problems. Okay, and by the way, this way of trying to maintain health, it's quite expensive and it doesn't work so well. And then the other way, it's free. Okay, get your sunshine, get your exercise, get your sleep, maintain your social relationships. Okay, this is sort of relatively free. You got to eat anyways, and everything works better and you live longer. So that's the smart way to go. All right, I make the metaphor here of a car, okay? Imagine you had a nice car, Rolls Royce. You just bought it. And the dealer's manual says, put premium gas into it. So what are you going to do? You're going to put premium gas into it, okay? Because if you don't put premium gas in it, you put in regular cheap gas in there, you're going to plug up the fuel lines. You're going to have all kinds of random, unpredictable problems. Well, guess what? It's the same thing with your body. Your body's like a car, sports car that you got to keep for hopefully 90 plus years. And so the smart move is, put the premium gas into it, okay? That's what you're supposed to do. So why don't you just do it? All right, so getting back to abdominal pressure syndrome, let me see, my next slide will tell me what I'm talking about here. Okay, this is hiatal hernia. So the hiatal hernia is when part of the stomach pushes up through the hiatus in the diaphragm, goes into the chest. Now, this is a big hiatal hernia. This is almost like most of the stomach in the chest. So we call this an intrathoracic stomach. Okay, and here it is flipped upside down. It can sometimes twist on itself, and that's called a gastric volvulus. Gastric stomach, volvulus means to twist on oneself and potentially constrict off the vascular pedicle that supplies blood to it, and the thing can infarct. That's rare, though. I only see a gastric volvulus about once every 5 years. So that is rare. But I see hiatal hernias all day long every day. And for the gastric acid reflux, the person is symptomatic, GERD, gastroesophageal reflux disease. They're often taking pills for that, like proton pump inhibitors, which is not a great medicine. It increases your risk of dementia, decreases your stomach acid, so you get less conversion of nitrites into nitric oxide, systemic vasodilator. So that's not good either. Reasons for a hiatal hernia. Number one, it can be partly genetic, sure. You can get muscle degeneration of the diaphragm, partly ischemic, from ongoing atherosclerosis from high-fat, high-sodium diets. You can have weak ligaments. Glycine phosphate, sprayed on GMO soy and whatnot, and some other non-organic foods. That has a glycine phosphate. The point being is collagen, your typical most important protein in your body. It's like 1/3 of the bodily proteins. Every third residue is a glycine. And Stephanie Seneff has written about how this can substitute into the proteins and replace the glycines. And so what that happens is you normally have a triple helix wrapped around of your collagen, and you start substituting glycines in there with that phosphate attached. They're bulky, and you can't twist up your helix, so your collagen, as well as you should, and so you're going to have weaker ligaments, and that can be contributing to this. It also contributes to spine disease. And F- can mess things up as well. F- has a tendency to damage collagen as well, substituting for hydrogens and making your collagen weak, and you get something so-called fluorosis of the spine, which looks very much like DISH, diffuse idiopathic skeletal hyperostosis, ischemic degenerative disease. Okay, lack of vitamin C, because there's a lack of vitamin C in animal foods, all right? So anyways, the whole point is the good stuff's in the plants, all right? In the plants, you'll get your vitamin C, you'll get your fiber, and if you eat them organic, you'll avoid the GP. You'd want to avoid F- in your water, fluoride, okay? Lack of fiber causes constipation. You get all the intra-abdominal pressure syndrome stuff, helping to push your stomach up into your chest. And being fat, when you're fat, your big fat belly is pushing on your stomach, increasing intra-abdominal pressure. So all these things contribute to pushing the upper part of the stomach into the chest, causing a hiatal hernia. it'll often get ulcerated. They're called Cameron's ulcer. They'll scope them. Sometimes people get iron deficiency anemia from it. And over time, the chronic inflammation can predispose to esophageal cancer. So that's that same mechanism again. Inflammation, fibrosis, tissue hypoxia, cancer. Okay, you see how it plays out all over the body? Okay, and esophageal cancer is a bad one. It's not that common, but when it happens, it's a pretty bad one. It's hard to do anything with the esophagus. Okay, there's some different subtypes of esophageal hernias. We don't need to go into all of that. Okay, here's a herniated stomach, like almost an intrathoracic stomach. And the point I want to show you is, look at this. It goes up behind the stomach, and it'll push on the left atrium. So, you're going to have impaired filling of your left atrium. What does that remind you of? The whole, Jack Delatory mouse equivalent theory of the brain. Okay, remember that? If you have suboptimal pumping of blood to your brain, chronically over time, the brain becomes hypoxic and you start losing brain cells. All right. So anyways, I'm just showing you how a giant HH can contribute to that. All right, here's a big hiatal hernia on a chest x-ray. You can see there's a big fluid level in there. Sometimes the patients, if they have an intact larynx, they're probably okay. But the worse this gets, the more you'll have food contents and stomach acid traveling up into the esophagus. And sometimes they'll aspirate it, cough it into their lungs. So here's a patient, got a big heart, so they're already probably in congestive heart failure. And now they've coughed some of their intestinal contents into their lung. It's an aspiration pneumonia. See how it's all clear over here on this chest x-ray? Whereas the right lung base has now got this fluffy, patchy infiltrate, and there's a little bit here perihilar and in the right upper lobe as well. Okay, now here's sort of the end stage complication of hiatal hernia is cancer. So you have abnormal thickening of the esophageal wall, somewhat eccentric, more prominent on the left side here, more than 5 millimeters. I would see that and go, that looks like esophageal cancer, okay? And the patient might have also aspirated. You've got some abnormal lung here, atelectatic or infiltrate, possible pneumonia. You got a left pleural effusion. So this is end-stage hiatal hernia, gastroesophageal reflux, creating a esophageal cancer. Okay, let's see what's next on our list of topics here. Oh, we're going to talk a little bit about the spine. So here's a picture of the abdominal aorta. And the reason I'm showing you is all of these diseases, I can see every single one of them on the abdominal CAT scan. And by the way, I've seen like about over 10,000 abdominal CAT scans, okay? I made up the term, as far as I know, of the Western abdomen pattern of diseases. I don't know, maybe someone else came up with it, but I seen it because I seen it every day. And I'm like, all of these things are related to each other. They're not separate diseases, because we learn in med school and radiology residency, all the books describe everything as separate diseases, and they never, ever put it all together. Okay, so here you can see the abdominal aorta runs down in front of the spine, and then it gives off lumbar arteries at the mid-height of the vertebral body. By the way, two VBs, the vertebral bodies and the adjacent intervening disc, that is a spinal segment. Okay, so lumbar artery runs mid-height of the VB, and it gives off a little twig to the upper end plate and the lower end plate. There's no blood vessel in the disc, but the disc is alive. That's an important point. The disc runs on anaerobic glycolysis normally. It receives its glucose by diffusion from the end plate of the vertebral body. And also it pumps out its waste products, again, by diffusion. That's another reason why we're made to walk. When you walk, you're kind of like milking in the glucose to the disc and facilitating the disc extruding its waste products. That's a normal good thing to do. Okay, so here's a drawing of it. Here's the lumbar vertebra. You count from below, L5, L4, L3. So that's lumbar vertebra number 5, lumbar vertebra number 4, lumbar vertebra number 3. And this is a normal looking disc. It's got an intact height, relatively flush with the posterior margin of the vertebral body. Okay, down here is the sacrum, S1, S2, S3 for the sacral segments. Okay, this is a very common area for people to have spine problems. All right, so what happens with the disc? The outer part of the disc is like a steel-belted radial tire. It's called the annulus fibrosus. And when it has a lack of oxygen to it, or sometimes it can be injured by trauma as well. And I also mentioned to you how you can have problems with ligament formation due to problems with excessive amounts of GP or excessive amounts of F-. Okay, so the steel-belted radial tire will crack, and a crack in it used to be called a tear, and it's called the annulus, by the way, annulus fibrosis. A tear used to be called a tear, but nowadays we call it a fissure because it has less implications. Because when you say annular tear, you're sort of implying a potential traumatic event, and it's thought a lot of times it has nothing to do with trauma. It's just a gradual degeneration due to ischemia and potentially the other things I just referred to. So when the annulus fibrosus, the outer steel belted radial tire fails, the center of the disc is called the nucleus pulposus. And the nucleus pulposus in the center, it's like a jelly donut. And the jelly donut starts leaking into the spots where the annulus is torn or it has a fissure. Okay, you can see them on a CAT scan, like on a T2 sagittal. You'll see a hyperintense band right here. So anyways, that's how a disc herniation occurs. Okay, I'll explain a little bit about disc herniations here in a moment. But that's an important point. The disc is alive. The outer part's a steel belted radial tire. It tears with hypoxia, trauma, and a few chemical problems. And then the inner part's a leaky jelly donut, and it leaks in. That's what's going on with the disc. Okay. By the way, I've written like a couple of books on spine. I used to run an entire spine clinic. I did tons of epidural steroids, transpedicular spine biopsies, et cetera, et cetera. I trained with a guy who who made the needle, Jeremiah Needle. Okay, anyways, disc osteophyte. So there's an old saying by Ralph Waldo Emerson from the 1800s. The hedgehog has only one trick, but it's the best trick. Okay, so what's the point? The spine is only one trick, to lay down calcification, but it's a great trick. So when the disc fails, let's say this is a collapsed disc, it's all narrowed. It's no longer able to distribute the weight equally between the VBs when you move. Okay, so what happens is the spine senses there's a problem. The spine has an important job. It has to protect your spinal cord and your nerve roots, your cauda equina. So it has a lot of proprioceptors to sense motion. When it senses abnormal motion in a spinal segment, localized segmental instability, it says, uh-oh, we got a problem over there. Start fusing that segment. So it starts laying down calcification bone, and then they grows up from this VB, grows down from this VB until they come together and fuse. And these are called osteophytes or bone spurs. When they're small, they sometimes call them syndesmophytes. So the spine will fuse. But imagine like this one fused first. If you fuse this segment right here, this is L4-5, you now are putting increased weight onto L5-S1, increased weight onto L3-4. So the adjacent segments have now an increased burden of weight that they have to handle. So they tend to fail more rapidly. This is called adjacent segment accelerated degeneration. Okay, and then they will fuse. And this whole process will march its way all the way up to the skull. And by the way, there were some papers about ischemic degenerative disc disease back in like the 1980s, but I figured out that it's not just degeneration of disc, it's all connected. The dish is connected, okay? The OPLL, ossification of the posterior longitudinal ligament. I'll show you on another page. Okay, so I'll get to that in just a moment. I figured out the whole thing's connected, the whole pattern of degenerative spine disease. And all the journals would refuse to publish. I submitted it to a bunch of journals. They all refused to publish it. All my neuroradiology, neurology colleagues, they all say, you're right, Pete. That's what's going on. So I'll show it to you. So here is a disc. It can herniate into the vertebral body. That's called Schmorl's node. It can herniate posteriorly, and that's called an extrusion when it goes above the disc space and below the disc space. If it remains at the height of the disc, then it's called a protrusion. And these are kind of like code words for small disc herniations, a protrusion, large disc herniations, an extrusion. There's actually more to it than that, but that's basically what they imply. You can also accumulate fat in the epidural space. It's called epidural lipomatosis, and that sometimes can be a lot. And the point I show you all this is there's a lot going on with the spine. And patients, I see tons of patients saying, oh, I need surgery for my spine. My back hurts. You know, you want to figure out why it hurts and do everything you can first before you jump into surgery. Okay, so now here's what I was talking about the way degeneration of the spine is all related to each other. So you'll have heard of degeneration of the disc. So degeneration of the disc manifests as a narrow disc space, loss of disc space height, gaseous disc degeneration, gas in the disc. But I'm the one who figured out it's all kind of the same thing and it's all related. This is DISH, bridging osteophytes. They're going to grow towards each other and fuse. DISH means diffuse idiopathic skeletal hyperostosis, also called Forestier's disease. But it's also related to OPLL, ossification of the posterior longitudinal ligament. It first fuses, the name of the ligament that travels on the posterior surface of the VBs is called the posterior longitudinal ligament. It initially ossifies along the posterior surface of the disc. The ligament attaches to the disc. So that's OPLL localized to the disc base. Because if you go back to the textbooks of the 1990s, they would say OPLL is a very rare condition seen more commonly in persons of Asian descent. That's absolute BS. I see it all day long, every day. Okay, a lot of the textbooks are, quite frankly, stupid. They're completely wrong. They're like almost irrelevant to what I see all day long on a daily basis. So this is the point I'm making, is you get OPLL, which is fusing these VBs together to prevent segmental instability, to protect the neural elements, okay? And you also get interbody fusion. You'll see calcification, ossification across the disc space, fusing the vertebral body, between body, vertebral body fusion. Okay, and I also see the same process happening on the spinous process. That's called Bostrup's disease. It just has its own unique name. There's an interspinous ligament and a supraspinous ligament, and those will fuse as well. And I figured out that it's all the same thing and it's all connected. I wrote a book about that. And I was pissed off the journals won't publish it because there's no money in it. If you start saying that people can improve their back pain by changing their diet and they need to walk more and stuff, where's the money in that? There's no money in that, okay? If you don't make big money happy, it's hard to get into the journals, okay? And also, if you're changing the paradigm, they don't like that either. They want somebody to take little baby steps to continue with the paradigm and figure out how to make more money. They don't want somebody who shows how to understand things from a whole new way. Okay, what are we going to talk about now? Maybe kidney stones. On my next slide will really tell me. Yep, we're talking about kidney stones. All right, so high meat diets will dramatically increase your rate of kidney stone formation. And part of what that's about is meat has a different amino acid composition than does plant foods. It has a lot more sulfur-containing amino acids, things like methionine and cysteine, and part of their metabolic degradation process is to produce sulfuric acid, causing a low-grade metabolic acidosis, which has to be buffered by the body. Part of the way the body handles that is the kidney will secrete the hydrogen protons, the acid protons, into the urine. And simultaneously with that, they'll secrete calcium, and that will lead to accumulation of calcium. You'll initially get calcifications in the periphery of the kidney, but you will then also have a tendency to form stones. A stone will form in the calyces here where the urine is. Yellow is where the urine is, and it'll dislodge and go into the ureter. So this is the renal pelvis. So this is a uretopelvic junction. Junction of the pelvis and the ureter, stone. That's a common spot for them to lodge. Also, even more common is for them to lodge distally, a smaller stone. We call this a UO, the ureteral orifice, or the UVJ, ureterovesical junction. Real common to see stones there. If they're small, 6 millimeters or less, they'll often pass all the way out. They're very painful. My dad had one. He said it's like being kicked by a horse. Okay, so you don't want these things. And I see them all the time. And the same patients who get follow-ups for kidney stones, they almost all got fatty livers. And the fatty liver patients have increased kidney stones. These diseases are all connected. Okay, then here is the leaky gut story. So leaky gut's a very big deal. And this is well worth knowing about. You might want to hit the little print screen button on here and save this slide. So these things right here are all things that cause leaky gut. So normally in your intestinal tract, what's supposed to happen is you're supposed to eat fiber. The fiber is taken by these good bacteria. I made them good bacteria with a smiley face. They convert the fiber into SCFA. That means short chain fatty acid. Most important one is butyrate. It has 4 carbons. 4-carbon butyrates are used by the gut lining cells. The gut's called the enteric tract. So these are called enterocytes. And they use the butyrate to make tight junctions. Tight junctions connect the cells. So that would be like a tight junction between, imagine my fists are the enterocyte cells, and the tight junction is a block. So nothing that's not supposed to can get past those cells. It's only a single layer thick. So that's how everything should normally work. Now, when you've got leaky gut, you'll have a breakdown of these tight junctions. And now the bacterial endotoxins like LPS, lipopolysaccharide, comes from gram-negative bacteria, or LTA, lipoteichoic acid, from gram-positive bacteria, can get across the gut lining. And it gets into the submucosal layer, the lamina propria, and the immune system will form a response to it. So you get localized inflammation of the gut wall, and that can cause diarrhea. It can cause stomach discomfort. And you'll also get big chunks of protein. Normally, only 3 amino acids connected to each other, tripeptides, the biggest piece of protein they can get across the gut wall. But now you're going to get bigger chunks of protein. And those chunks of protein, when it comes from an animal, it'll have an amino acid sequence that's a little bit different than ours, okay, so that our immune system will form a response to it. But it's similar enough to ours that those antibodies formed to these abnormally large chunks of protein getting across the gut wall, they can cross-react with our own body. So the similarity of its amino acid sequence, it being an animal, us being an animal, is called molecular mimicry. And the fact that that same antibody that responds to the digested protein can cross-react with our body, that's called auto. Auto means go against our own body. Cross-reactivity. And that's what autoimmune disease is. This is the most common mechanism of autoimmune disease. Okay, so if you had an autoimmune disease, first thing I would do if I had autoimmune disease, I'd go through this checklist of what causes leaky gut, and I would avoid all these things. And I would make sure I was eating a lot of dietary fiber. Okay, so there's a lot of things, and there's a lot of these things real common. If you're eating oils, antibiotics can do it. Glyphosate, GP, was initially patented as an antibiotic, so it does this as well. Okay, alcohol does this. Excessive psychological stress, I think it makes the gut a little bit ischemic, because you don't need to use your gut when you're running from a tiger being chased in the dark. Okay, caffeine's a stress equivalent. Sleep deprivation is a stress equivalent. Alcohol, kills stuff. Okay, we use alcohol to sanitize the skin. Okay, emulsifiers and fats. There's some. I'm not going to get into all the mechanisms of fat, but fats increase leaky gut in general, and emulsifiers are like a fat. They're sort of part polar, part non-polar. They can hold the fat phase and the aqueous phase of processed food together. That's why they're in all the processed foods. And there's a whole bunch of them, okay? So you want to avoid these things. And then that was the autoimmune story. There was also the localized stomach discomfort, but there's an additional story. There's the issue of abnormal clotting. This LPS or LTA, bacterial endotoxins that can get across the gut wall, they then will interact with your blood clotting proteins like fibrinogen, and they're going to change the shape from being like a cylinder, that secondary protein structure called alpha helix. They're going to change it to becoming flat, and that's beta pleated sheet. And these beta pleated sheet flat protein shapes can stack up with each other and form these clots called amyloidogenic clots. It'll make more sense in a moment, but trust me, that's a big deal because infections can do that. Viral infections can do that. That's a big deal. Okay. All right. Well, here's a better picture of it. So here's a gram-negative bacteria. Here's a gram-positive bacteria. Endotoxin for gram-negatives, LPS. Gram-positive bacterial endotoxin, LTA. And those are getting absorbed into your blood. Then they will interact with fibrinogen, the blood clotting protein. Again, it begins with an alpha helix secondary protein structure, which is like a cylinder, or it's like a slinky. You can imagine it that way. Okay. And that's a good shape for it to be. That's how it's functional, and it does what it's supposed to do. But when it interacts with these endotoxins, these intra means inside of, intramolecular hydrogen bonds become intermolecular hydrogen bonds. So what I'm saying is, instead of holding itself together like a slinky, they now interact with the adjacent protein of the same type, and they form beta pleated sheets, which is a flat secondary protein structure that's flat, and they will stack up like a deck of cards. And that's bad because they will form relatively large clots that are an unnatural form of a clot. They also called dense matted deposits. And these are more difficult for our blood system to lyse, to remove, to dissolve. Okay, so these clots will travel around in our blood. They can plug up capillaries in our brain, cause some brain damage. They can plug up capillaries in our heart, cause some heart damage. And so what I'm saying is these occur from leaky gut, and they also occur from viral infections as well. Okay, so bacterial infections, you don't want these. And then what makes it worse? If you're iron overloaded. Lots of people are iron overloaded. I was a little bit iron overloaded myself when I was younger because I didn't know. When I was young, I thought, you want to eat a lot of meat, be strong like a lions and tigers, okay? And I used to intentionally eat all this cereal that was iron fortified, like Raisin Bran. I thought that was the best thing to be strong, like Popeye, okay? He eats the spinach for the iron. Okay, so anyways, if you get increased iron levels in your blood, and it's indicated by your serum ferritin, you'll have more oxidative stress because iron tends to have two valences, Fe2 plus and Fe3 plus, and it can cycle back and forth between Fe2 plus, Fe3 plus, Fe2 plus, Fe3 plus, and in the process of doing so, become autocatalytic and give off electrons to local oxygens, and those oxygens will become ROS, reactive oxygen species, and that causes oxidative stress. All right, so we're not going to get into all that today, but what I want you to know is leaky gut's a big deal. Leaky gut's very common, and the way you prevent it is avoid those things on that list and eat more fiber. Okay, so you help avoid all these clots, because also people have other medical problems, and they're like, how can I get well? And one of the things I tell people is, you want to do everything right, as perfect as you can for optimizing health, and then your body will often help you to heal, okay? And it kind of reminds me of like the Robert Pirsig Zen in the Art of Motorcycle Maintenance quote. He says, how do I make a great painting? He says, well, first of all, make yourself a great artist, and then you'll make a great painting. It's a bit of a joke, but it's true. All right, now here's two people that are good to know about. Her name is Etheresia Pretoria. She often calls herself Resia. His name is Douglas Kell. They're both PhDs. She's from South Africa. He's from England, and they've done great work. They also deserve a Nobel Prize, but they're never going to get it, okay? Because their work is, simplifying things. Nobody wants that. All right, so here's a normal clot. Here's a red blood cell, and here's normal thrombin and fibrinogen. They look like pieces of spaghetti, and they start to wrap around the red blood cells and pull them into a clot. But when you've got excessive iron, or you've got LPS or LTA, they will distort the shape of the red blood cells, and they'll form these sort of ugly clots that are, they call them dense matted deposits. And these are harder for the body to lyse. And these guys figured this whole thing out. She's got more of a hematology background. He's real good with microbiology. They figured out a lot of stuff that connects all of that. Okay, so here's normal red blood cells. Here's a distorted shape of a red blood cell thought to be due to oxidative stress related to iron overload. This is abnormal fibrin forming abnormal clots. Dense matted deposits, this big bulky thing, rather than clots looking like pieces of spaghetti laying all over each other. And it's harder for the body to clear these. And what I'm trying to say is a lot of people are carrying these around post-leaky gut, post-bacterial infection, post-viral infection, and it's contributing to their morbidity, their overall sickness. So if I was worried about this problem, I would try to minimize all my clotting risk factors and give the body more reserve to help fix this problem. Okay, this is just some of the papers I've written. Again, this is Pretorius and Kell, where they showed LPS does this, iron overload does this, LTA. So they're all causing what is also called amyloidogenic clotting. Amyloid means to change the shape of a protein from alpha helix to the beta pleated sheet, and thus have it function abnormally. So you can call it amyloid clotting, amyloidogenic clotting, and it's important to get that concept. And another reason that's useful about that concept is amyloid formation, like beta amyloid proteins that sound familiar, is related to the cause, one of the mechanisms for dementia causation. I actually think it's kind of a minor contributor, but it is relevant to dementia causation. So we're going to talk about beta amyloid protein a little bit in this lecture. I've talked about it more in other lectures, but I'm letting you know this idea of amyloidogenic transformation of a protein from its functional alpha helix cylindrical shape to flat beta pleated sheets that stack up on each other and precipitate. That's useful to know, because when everything in the body normally functions in aqueous solution, and like water. Okay, and the bigger a molecule is, the more likely it is to precipitate out, become a solid rather than dissolved in solution. It has to be dissolved in solution to be functional. So when you start stacking things up and they all stick into each other from intermolecular hydrogen bonds, they precipitate out of solution, they become dysfunctional, and then they now have mass-like properties that push on other things and make them dysfunctional. Okay, so this paper is like genius. This is an AO, academic orgasm. Okay, hallelujah. Okay, it's so beautiful, this paper. And anyways, these guys figured this out. It's really pretty neat. And then they also believe that this is a major contributor, in their opinion, to so-called Alzheimer's dementia. Now, I've talked about dementia before. I don't even believe in the word Alzheimer's. I think that's kind of a joke. However, do I think this is contributing to dementia? Yes, I do. But it's not as important as they think it is, in my opinion. Everybody who comes up with a theory always thinks theirs is the most important. Of course, I think mine is the most important, but I'm right. I'm not biased. No, I'm biased too, of course. But anyways, just letting you know, this is all contributing. There's a lot of mechanisms that contribute to cognitive impairment. Of course, aluminum is a major neurotoxin that contributes. Okay, omega-6 cooking oils end up being neurotoxic. That contributes. F- in the water, that contributes. Okay. Brain hypoxia, that contributes. Okay, we're not going to get into all that today. It's not the focus today, but I wanted to let you know this amyloidogenic clotting, there's good reason to believe that it contributes to cognitive impairment. And I think it's also contributing to cardiac impairment as well. So once you know it, then you got a better chance to avoid it. Because, imagine you're walking down the street, dum-de-dum-dum-dum, and then a car starts coming towards you. You're like, uh-oh, here comes a car. I will jump out of the way. So when you're aware of a potential danger to your health, you then have a much better chance to avoid it. And so being aware of this, and now you know the mechanisms, I just showed them to you, you can avoid it. Okay, avoid leaky gut, avoid iron overload. That's what you do. Okay, here's just a localized problem from leaky gut. You'll get inflammation of the gut wall. This is ulcerative colitis. So there's been a lot of patients with ulcerative colitis, Crohn's disease, that had dramatic improvements in their health by fixing their diet, avoiding toxins that cause leaky gut. And you look at this and you see this all the time in the patient. Notice the spleen is relatively dense, like it normally is. And notice that the liver is less dense than the spleen. The patient has fatty liver. And this is a typical example of how these diseases go together, okay? And I can also tell this is a young patient because they don't have any degenerative disc disease of the spine yet, okay? I can see just part of the kidneys, no stones in them yet. So this is a young patient who's heading down that path of one problem after another. And the smart move is to say, when you got a problem, fix it. The sooner the better before it becomes a big problem, before it becomes irreversible. Okay, we're going back to our gynecomastia, pregnant female body type man. So we're probably going to talk about estrogenic stuff. Oh, so here it is. These estrogen chemicals cause an increase in things that grow with estrogen, which means breast tissue, breast ductal tissue, and also the uterus tissue. So here's a benign tumor. This is the uterus. So we're looking at a female. This is a sagittal image, like from the side, sliced from side to side, if you will, on the MRI. And you can see here's the urinary bladder filled with urine, and here's the uterus sits up on top of the urinary bladder. Here's the endometrial stripe in here, and here's the muscle, the myometrium. So this is a benign tumor of the uterus muscle, and it's called a fibroid or a leiomyoma, and it's projecting outward from the uterus. When something projects out, that's called exophytic. So I would describe this as uterine fundus with large exophytic fibroid, about 6 by 7 centimeters in diameter, and high estrogen levels will increase this. I've had some women tell me every woman in their family had to get a hysterectomy before age 35 because of fibroids. And you know what I say to myself? You're all a bunch of meat eaters, processed food eaters. You're drinking tap water probably, and you're using a bunch of personal care products, and you're not eating enough fiber. All of those things will increase this. And then if you look at this one, at first glance, this looks like another big uterus. But guess what? This is a guy. He's got a Johnson here, okay? And by the way, that's the difference between a man and a woman. A man has a Johnson, a woman has a Virginia. It's not that complicated, despite what you might have heard at your local university. Okay, so this big prostate, this is a giant prostate. This is the prostate that ate New York City. They're usually not this big, okay? But this is a big one, and it's pushing on the urinary bladder. So as you can well imagine, this guy probably wakes up a lot at night to void, all right? And again, this is a lot bigger than the regular prostate. That's a giant one. All right, now here's estrogen. And the reason I'm going through this is all this estrogen stuff, it affects the abdomen. I just showed you fibroids, and I just showed you giant prostates. Okay, so here's the cholesterol backbone and the estrogen molecules, the estrogen produced in the body. We call this, our intrinsic estrogens, our endogenous estrogens. It'll be formed on a cholesterol backbone. That means there's 4 cyclic rings. The A ring is the important one. Remember A for aromatic. It has 3 double bonds in an estrogen molecule. Normally, cholesterol doesn't have that, but in an estrogen molecule, you'll have 3 double bonds here. That makes it called an aromatic ring. It can also be called a benzene ring. It has a smell, an aroma, so it's called aromatic. It'll have a hydroxyl group coming off it. Hydroxyl group can also be called an alcoholic group. The 3 double bonds will resonate amongst those carbons. They'll move around, and that allows the electrons a lot of free run all through the 6 carbons in there because it's a cyclohexane. So the point of it is that it has great shelf life stability. For years, that can sit on a shelf and not degrade. Companies love that. And the hydroxyl group makes it antimicrobial, antifungal. So this is the perfect chemical for industrial use. It's called a phenol group, this combination of the aromatic ring and the hydroxyl group. So that's in all these preservatives. You almost can't find a product that won't have something related to this in it. The way the phenol group interacts, or the estrogen molecule interacts with the estrogen receptor, is that hydroxyl group, it forms sort of a shared hydrogen bond with the receptor active site. Okay, so anything that's got a phenol group on it will very often interact with estrogen receptors. All right, so here's a typical molecule from common life. It's called bisphenol A. Bis means 2. So there's 2 phenol groups, and bis means when they're not touching each other. They're on different parts of the molecule, and you got 3 carbons in between, okay? So bis 2 phenol groups. So 2 phenol groups on this molecule. And people say, oh, bisphenol A, it's a terrible molecule. It ends up being a mitochondrial inhibitor. It has feminizing properties, estrogenic properties. We should not use that in baby bottles or other plastic bottles for water or for other things. We got to get rid of it. Ban it, ban it. And so the companies go, okay, fine. And they just put a sulfate group in the center. It doesn't matter. Now it's, bisphenol sulfate. Whoop-de-doo. You're still going to have the phenol group. So what I'm saying is you can never get companies to ban these molecules because they can always just change one substituent on the molecule and just get the same effect. So it's a waste of time to try to get companies to change. The real smart move is learn how it works. It's not that complicated, and just avoid this stuff. Okay, and there's a whole bunch of other ones. I'm not going to go into all of them, but power-benzoic acids are a common one in deodorant. Women are putting deodorants on there with these estrogenic properties, shared lymphatics from their armpit to the upper outer quadrant of the breast. Incidence of breast cancer upper outer quadrant has increased from 30% to 60% since the 1920s. There's thought to be your answer, okay? Now, here's another important point, getting back to our abdomen specifically. Your body, when it has high estrogen levels, it sends the estrogen to the liver. The liver does something called conjugation, meaning it adds another molecule to it to make it more water soluble. And it's called a glucuronic acid. Think of a glucuronic acid as being just sort of like a glucose plus a carboxylic on it. So it makes it more water soluble. The estrogen connected to the glucuronic acid is excreted into the bile. and then passes into the intestinal tract, and normally it is defecated out of our body. That's how we lower our levels of estrogen. However, there's only two types of gut bacteria. I know you hear a lot of things about gut bacteria, but don't drive yourself crazy about it. You only need to know there's two types. There's good and there's bad. Good bacteria are fed by dietary fiber. The bad gut bacteria come from eating, a meat processed food diet. And what ends up happening is these bad bacteria have more glucuronidase. And days, means enzyme that cuts something. So it will cut the conjugation linkage between the estrogen and the glucuronic acid. And once that linkage is cleaved, now the estrogen is absorbed into our blood. So people who eat low fiber diets, a lot of meat and processed foods, they will have higher bodily estrogen levels. They also have high estrogen because they'll typically give a lot of these animals, these livestock animals, estrogenic chemicals because it's a fat storage hormone to make them gain weight faster. So they're high in estrogen to begin with, and then you're eating a low fiber diet, you're absorbing more estrogen into your body. So you don't want that. That's how people become really estrogen overloaded. The other thing is at the base of the heart, we can see the calcifications on the abdominal CAT scan. We always get a couple images through the heart at the bottom, at the top of the abdomen, because we don't want to make sure we don't miss the diaphragm, top of the liver. All right. So anyways, I'm going to talk briefly about cardiac calcium. So the first question is, should I go and get a cardiac calcium scan to the hospital? And I'm saying, no, I think that's stupid. And the reason why I think it's stupid is you already know if you ate the SAD diet for a couple of decades, you've got coronary artery disease. You don't need to go get a CAT scan to prove it. What good is that? The only relevance is I'll sometimes see a patient and they really just can't understand anything about the physiology. They don't get it. So then they see the CAT scan. They're like, oh, my goodness, my heart has calcifications in it. Then they get all worried, and hopefully that'll motivate them. But I'm like, why give yourself the equivalent of thousands of checks, x-rays, and radiation for nothing, for something you already know? Stupid. Okay. I drew in here abdominal aortic aneurysms, but they're relatively uncommon. Yeah, they sometimes happen, but it's like how many people die from shark attacks, okay? There's a lot of drama to abdominal aortic aneurysms, but they're not that common that they're big. I see a lot of little ones. I don't see too many big ones. Okay. Coronary artery disease. Here, I got a tale of two patients, a tale of two cardiac patients. So here's your average chump. Okay, I got this term from the PUA literature, the pickup artist literature. Mr. Average Frustrated Chump. Okay, he's got coronary artery disease, cardiac angina. He's real proud of his carnivore diet, thinks it makes him strong and macho like a lion, thinks his beer belly's a joke, thinks his moobs are a joke. His Johnson's not working so well. His wife's making fun of him. The cardiologist sends him for a stress test. Dr. McDougall's described the stress test as a conveyor belt to the operating room. They typically go to the cardiac cath lab first. They often get a stent, $30,000 of billing for all the charges related to that for each stent. But there's often a spot they can't, stent. It's too far distal or it's in the left main. They call that the widowmaker. If you got a so-called widowmaker, then they recommend CABG, coronary artery bypass graft surgery. He sent the guy for CABG. My father went for this many, many, many years ago, decades and decades ago, when I was too young. I told him to follow the Ornish diet, but I was a young guy at that time. I didn't know enough. And the cardiologist and cardiothoracic surgeon pressured him, and he went for CABG. I stayed with him in the ICU throughout his hospital stay. They ran his blood pressure really low, something like 90/60, or maybe it was 95/60, which is incredibly low. And I asked the anesthesiologist why he run his pressure so low. And he said, we don't want him to bleed out the anastomoses, the plug-in sites of the graft. And my dad came through it okay. I think he was much healthier than the average, patient. My dad was a physician and he did exercise. He played tennis and stuff. And he was trying to improve his diet, but he thought, eating salmon was a good idea. No, stupid. Salmon's 50-50, 50% fat, 50% animal protein. That's a bad combination. Okay, well, this not my father. My father came out of his CABG fine, but I'm talking about patients that I see on a routine basis. I've seen many thousands of patients come through CABG surgery. This patient in particular, for the purpose of our comparison, had a small stroke. They thought he couldn't protect his airway that well for a while. They put in a gastrostomy tube. They left the epicardial pacemaker wires going into his heart's external surface just in case. The sternotomy site got a little bit of infection, osteomyelitis, that's a bone infection. So they put in a PICC line, that should be PICC, PICC line for antibiotics. He's kind of got, you would call a mild, he's got a bit of a, not mild, he's got multi-organ failure, MOF, congestive heart failure, his heart's not working as well as it used to, acute renal failure, respiratory failure, he had to get trached, and a little bit of brain failure, a little bit of cognitive impairment, and he's a little bit cognitively slow. You can chronic hypotension, running the pressure low for a prolonged amount of time, it's a mouse equivalent. Okay, And then he saw the lecture, McDougall's lecture, showing that stents and cabbage have essentially about a 0% increase in prevention of future MI or increase in longevity. So he's a little pissed off. Okay, now here's our other patient, a little bit smarter guy, a little bit more fortunate guy. He knows he screwed up with the SAD diet. He recognizes and accepts that it was his own fault for eating the wrong diet. He just didn't know. He starts watching nutrition and health videos online, all for free. He learns about Caldwell Esselstyn's diet. He reads his book, watches his video, becomes a low-fat vegan. His body weight starts coming down. His Johnson's, working a little better. His wife's annoyed because he's acting like a newlywed. He goes to the grocery store. He's a little frustrated, not so sure what to buy. He's lost so much weight. He's going to have to buy new clothes. That's going to cost him some money. And initially, when he changed his diet, he was kind of intermittent, on, old diet, new diet, old diet, new diet. And he's getting a little bit of a Hershey squirts in his underwear. So he's a little pissed off. What I'm basically saying here is, which patient would you rather be? This guy's just, been billed for $180,000 to an insurance company. I don't know how much comes out of his pocket, and he's got a bunch of problems. This guy's a little annoyed because he's got the Hershey squirts, and his wife, is not thrilled. Okay. All right. Now I'm going to show you something else too. Okay. When Jesus Christou was crucified, he had 5 wounds, 1 in each hand, 1 in the chest, 1 in each foot. Okay, there's Longinus, the Roman soldier, with the spear in his side. All right, and when he placed that spear in his side, what came out of it was collected in a cup, the same cup that had been used at the Last Supper, and that is the Holy Grail. And it is thought that the Holy Grail has incredible healing properties. Okay, and so here is the Knights of King Arthur at the Round Table, and the search for the Holy Grail. And you had to be good. You had to do everything you were supposed to be able to find the Holy Grail. So even though Lancelot was the best knight, he had gotten himself into a little bit of risky business with Guinevere. So he was no longer considered worthy to find the Holy Grail. But Sir Galahad was. Okay, so what I'm trying to say is, here's what I would call the 5 wounds of the village idiot. So once you know how much better, I don't know if I can move this thing here, if I can see it. Once you know how much better low-fat vegan is for your routine coronary artery disease or chronic angina, it's a no-brainer. And so these are the typical wounds of a typical cabbage patient. First of all, they get the big sternotomy. A rotating buzzsaw opens up the chest, crack the chest, peeled apart with these retractors so they can get access to the heart. They put in a right internal jugular vein Swan-Ganz catheter to keep track of the pulmonary artery pressures, which are an indicator if the guy's going into congestive heart failure. They need a mediastinal tube to check for bleeding at the anastomosis sites in the chest. They need one also in the left pleural space to see if there's bleeding into the left chest. The cardiac cath, they had a large diameter sheath in the common femoral artery, common femoral vein, and they'll often close it with a perclose device or something, so they got a wound there. So those are the 5 wounds of the village idiot. Somebody who, after knowing all this, would still choose cabbage rather than just go low-fat vegan initially. And then the one thing I joke here is that when I was a young guy, I thought that the real experts on atherosclerosis were the cardiologists, the cardiac surgeon, and the vascular surgeon, and the interventional radiologists, imaging guided surgeons, which I was. And I did a lot of work in vascular disease initially when I started out. But then I kind of joke that they're like plumbers in the sense that their job is to see a blockage in an artery and to fix it. Can we bypass this with a surgical graft? Can we get across the blockage, open it up with an angioplasty balloon, deploy a stent in there? Okay. But there's something a little stupid about that too when you think about it, because they're going to tell you the main mechanism in conventional textbook of myocardial infarction and a heart attack is that you have a rupture of an atherosclerotic plaque and then it clots off the artery. Well, what happens when you put a balloon in there? You rupture atherosclerotic plaques. And people say, well, the stent's on top of the balloon and it traps the plaque. Well, if you actually look at an angioplasty balloon and stent, the balloon extends proximal and distal to the stent a small amount. Okay, you're rupturing plaques still, okay? But I don't think that's as key as people think it is. But anyways, I just thought this was funny that, this plumber, because he's seen things in a different way. He said, you dishonor your profession, Billy. It's a joke. But what I'm saying is, if you ask all these guys who I used to think were the experts, the real experts are the pathologists who study atherosclerosis because they look at it with a microscope. And these other guys, they have an agenda in a field that they have to respect. If you're a cardiologist, you can't criticize stents or they will kick you out of their hospital. If you're a cardiac surgeon, you can't criticize a bypass graft. They will kick you out of their hospital. They're making $120,000, $150,000 a piece. You think they want some guy talking about that? A vascular surgeon's putting in grafts? No. They don't want to hear a word about this low-fat vegan stuff, okay? And I've changed, and I just stopped doing vascular work, so I can talk about it now. But if I'd been back in my old days of my old places, they would not have liked me saying low-fat vegan's the way to go. I'm not going to talk too much about screening studies, but I'll just say one thing. There's a joke in radiology. What's the definition of a healthy person? The definition of a healthy person is somebody who hasn't had a body CT yet, body CAT scan. Body CAT scan means chest, abdomen, and pelvis. And the reason is you always find a whole bunch of incidentalomas. I mean, I don't think, good luck scanning any person over 30 years of age that's not going to find one incidentaloma. When I say incidentaloma, there's going to be a micronodule at the lung base, probably nothing, an old scar from many years ago, but you don't know, get a follow-up. A kidney cyst, probably a benign, simple cyst, but there's some density in the center. Maybe it's just machine noise, but you better get a follow-up. Maybe send them for an ultrasound. The adrenal gland's looking a little big. There's a low-density lesion in the liver, too small to characterize. Get a follow-up. What I'm trying to say is, even if the first scan was free for screening, they have a very, 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 very high likelihood of having follow-ups that could empty out their wallet pretty rapidly and cause unnecessary treatments. This guy, Gilbert Welch, is a really smart guy, and he wrote a really good book called Overdiagnosed. He also has a YouTube channel. Here's his YouTube channel. You can go there, you can watch his videos about all the issues with these screening studies. And in his opinion, this is a real smart, experienced doctor. He said, overdiagnosis is the biggest problem in medicine, and the patients love it. Patients think it's like playing the lottery. Oh, I can be saved from my cancer. And I can tell you, I've had experience with screening for over 30 years, and I wouldn't do any of this stuff, any of these imaging screening tests, okay? I would never want to scan my abdomen or something and have all these incidentalomas and be stuck following them. I think it's good to know your blood pressure, know your total cholesterol, your serum ferritin, your vitamin B12 level, a few other things maybe, but screening itself is quite overrated. The way I would describe it is, imagine you were walking at the shopping mall, and there was a couple of guys on top of the roofs of the stores at the shopping mall, and they threw a net down on top of the people. And it's sort of like, that's what screening does. It says, okay, all you healthy people, you healthy citizens walking around, now you're mine. Now you're a bunch of patients. You all have diseases, and you're going to give me money every year. So you turn normal people into patients, and they're asymptomatic, okay? You know, you're not going to improve your quality of life beyond asymptomatic. And the other thing is, people don't tend to know the 3 types of cancer. This comes from George Cryle at the Cleveland Clinic, and he described cancer as being 3 types. Imagine you were a farmer and you owned a big farm, 100 square miles, and in the center of it, you had a fenced-in animal enclosure. Here's the fenced-in animal enclosure. And you had vultures, turtles, and rabbits. Well, if the vulture escapes from the animal enclosure, you're screwed. It's going to fly over the fence. It's gone. You can't screen for it because it happens so fast that it'll kill the patient during the screening interval. And the point about vultures are, they're incredibly rare. If somebody gets a vulture cancer, you make a movie about them, okay? A young person gets one, make a movie about them. It's really, really, really rare. Okay, then the next thing is a rabbit. The rabbit digs under the fenced-in enclosure and makes a run for the fence. And that's what everybody thinks cancer is. We got to stop it. We got to stop it. Do surgery. Do chemo. Do radiation. Now, now, now. Go, go, go. Okay, here's the reality of cancer. Most of them are turtles. And even if somebody forgot and left the gate open on the fenced-in enclosure and the turtle starts making a walk towards the fence, it's so slow growing, the patient almost certainly is going to die of something else. That's what most cancers are. So you want to be careful about diagnosing them. You want to be careful about treating them, because what ends up happening to tons of people is they go for a screening study, they diagnose a turtle, they think it's a rabbit, and they give the patient chemo and surgery, okay? And then the patient gets complications from the chemo and the surgery that they would have been better off not even knowing they had a turtle. That's very common with prostate cancers, okay? And look at the Ornish study. A bunch of patients just went vegetarian and sort of had good stress management, okay? And they kept or lowered their PSAs, prostate-specific antigens, the blood indicator of prostate growth, rather than the ones who went with the same old, you know, sad diets and whatnot. They had a tendency to their PSAs to drift up and then need to go on for surgery, radiation, and whatnot. So what I'm trying to tell you is, you want to be intelligent about it so you don't end up stuck with all this stuff. And the people who really know a lot about screening, like myself, I've been involved in it for 30 years. I wouldn't do it myself because I know about it, okay? And I know that more people are hurt by it than helped by it. Oops, I got into the wrong thing there. All right, so there's another joke in radiology. What's the theme song of radiology? It's Hotel California. You know what that means? Remember the song Hotel California? You can check out, but you can never leave. What it means is you're always going to have to come back for follow-ups. So you don't want to image something unless you have a good reason. It's not like there's no cost to imaging. There potentially really is. And I think the biggest cost is incidentalomas. And I think that's one of the biggest problems with all these screening studies. And Gilbert Welch thinks it's the biggest problem in medicine. He wrote that book, you know, I don't know how many years ago, maybe 5-10 years ago, but he's a smart guy. So the thing I joke about is the difference between a health expert who knows about low-fat vegan diet and toxicology compared to somebody just with conventional medical knowledge, it's like the difference between a Gulliver or a Lilliputian. And the people who run the medical system, they know that Gulliver is powerful, so they gang up on him and they tie him down because they don't want Gulliver's teaching the medical system all about this low-fat vegan diet and toxicology. Because you know what they say in conventional medicine: if you cure a patient, you lose a customer. All right, you never cure them with a pill. You know, match the ill to the pill and send a bill. Like when I was in med school, I thought, isn't this great? You just match the ill to the pill, send a bill, and everybody's happy. But the reality is the patients don't get better and they don't get cured. They might get a little better, and it might slow things down a little bit, but in the long run, pills are quite overrated. Okay, so this is a diagram. We're almost done here, but just a few philosophic thoughts, and we'll talk about how to prevent and treat disease. As a conventional doctor looks at diseases as all individual separate things. So here's D1, disease 2, disease 3, disease 4, 5, 6, all the way up to 15 diseases. Okay, and they're all separate things treated with different types of pills, different types of surgeries. Okay, and then in the center is how a person who knows nutrition, epidemiology, and toxicology thinks. They look for patterns. I'll explain that in just a moment. And they also try to optimize everything. The standard of care is almost always going to be drugs and surgery. And part of that's because a lot of the patients really can't do much. A lot of them are cognitively very slow, no motivation. Some of them are intoxicated. Some of them are demented. So what I'm trying to say is you can't expect them to do anything other than take their pill or go for surgery. But for the person who's motivated, they can exercise, they can change their diet, they can get more sunshine, they can get more sleep. They can do a lot to improve their own health. So again, this is how conventional medicine thinks. Disease 1 through 15, 15 pills, match the ill to the pill, send a bill. That's a great way to sell drugs, but patients never cured. Okay, and to some extent, I think it's the blind leading the blind, and we know what that's about. Blind leading the blind, they all fall into a ditch. Okay, so what am I saying is a better way? A better way is to remember, this is like an Indian proverb: the 5 blind or 6 blind men and an elephant. Okay, the first guy feels the elephant's tail and he says it's a rope. Next guy touches the side of the elephant and he says it's a wall. Another guy, takes the leg. He says it's a tree trunk. Okay. One on the ear, it's a rug. Okay, so the point is, if you look at the different aspects of understanding a disease, read about what are thought to be the mechanisms of disease, the biochemical mechanism. What is your personal experience? Other people you know, other people on the internet. What's the comparative anatomy of the region of the human, whatever? Okay, what are the animal studies? What is the human research? What's the epidemiology? You look at it from all these point of view. So instead of being like the blind man who only knows one thing, you want a bird's eye view so you can kind of look down. So here's sort of a classic painting of a bird's eye view called Wanderer Above the Sea Fog, a beautiful painting by Caspar David Friedrich. Okay, so he's looking down out, and then when the person has his back to you, it's kind of a cool way to make a painting, because then you, the viewer, feel like you're in the painting, or you're like the guy looking down. Okay, so anyways, the point is a bird's eye view. You see the big picture. And this is also called the romanticism style of painting, whereby the individual is relatively small in comparison with the powerful environment around them, okay? And that was sort of a reaction to neoclassical style of painting, but it's beautiful. All right, so anyways, now we are looking at our health expert who knows nutrition and toxicology and epidemiology. And he looks at these diseases: GERD, leaky gut, irritable bowel syndrome, constipation, varicose veins, autoimmune disease. He says, hey, these are all the same thing: lack of fiber and things that cause leaky gut. So let's just avoid that, and we can avoid all these problems and help improve outcomes with all these conditions. Sounds like a good idea, okay? He looks at these diseases over here: coronary artery disease, hypertension, diabetes, kidney stones, osteoporosis, gallstones, low back pain. He goes, gee, these are all pretty much caused by the same thing. So we'll eat our plant-based diet. We'll avoid, these animal foods, high fructose corn syrup, caffeine, these non-organic chemicals here. And we could probably avoid all these things or dramatically lower our risk of getting them and dramatically improve our outcomes. Let's do that. Okay, and then he sees, cancer, memory problems. Or kind of here a few additional things to be aware of. There are some mutagens that are real, and there are some excitotoxins that are distinct from all this stuff. And that's one thing I think why I like to focus on the brain, not just the heart. Because typically internal medicine perspective is, if it's good for the heart, it's good for the brain. And that's true. But the catch is the brain's a lot more fussy than the heart. So you got to be careful about some additional things if you want to optimize brain health and brain function. But the point I'm making is there's really sort of like 4 categories of disease, and there's really sort of like 2.5, because these are just a tiny bit of additional stuff compared to these other ones. Make it 3 categories. So there's not 15 things to be aware of. There's three major categories of disease here. And you can get much, much, much better outcomes being aware of this stuff. That's why it's worth knowing all this stuff. Okay, and so it reminds me of the joke from the movie Colors. Okay, in Colors, they talked about the joke, and basically there's two bulls on a hill. One's a young bull, one's an old bull. And the young bull says, hey, look at all those cows down there. Why don't we run down there and we can have sex with one of those cows? And then the old bull says, why don't we walk down there and we can have sex with all of them? Okay, so I'm kind of joking, but the point is, why just try to treat one disease when you can treat them all the same way? Why not? You win the game of health. That's what I do. I know a lot about health. I've been studying this for a long time. I devoted my life to it. Okay, and I can tell you, that's the smart move. That's the best chance you have to win the game of health. Why not do it? And it's free. And in a sense, it's like Super Mario Brothers, okay? Like any video game. A video game character is going through an obstacle course, and there's certain good things to do, like you get points. You get the green points, and they increase your resilience, your reserve, make you healthier, stronger, more powerful, okay? And then there's other things you do where you screw up, okay? And, one of the monsters bites you or something, you lose energy points. It makes you sicker. So what I'm saying is good health habits are getting the green energy reserve points, and the bad health habits are the things that knock you down a notch. So you want to avoid them, okay? So learn the good stuff, avoid the bad stuff. And here's what I call the Spartan vegan diet, which is really just a variation of the same low fat, low sodium, 100% plant-based diet, preferably 100% organic. And I recommend it. It's primarily most calories from starch. Fruits, I think, are also really good. They're less available, though. They're a little bit seasonal. And fruits also, they don't store as long. They're more expensive, but I do like fruits. Veggies are good too. Again, not as widely available, and I'll eat veggies too, but I'll get most of my calories from starches. I've heard different people recommend you should get 90% of your calories from starches. Others say, 50 or 60. I probably get about 60 typically. I probably get about 35% typically from fruits. I don't plan it. I don't think about it. I just eat these foods, and that's what it ends up being. And I try to always eat, a salad or some type of veggies every day if I can. Sometimes I forget to get them. And these are sort of like your basic psychosocial things that all make you healthier. And the only supplement I take is vitamin B12, methylcobalamin, the one that can dissolve in your mouth. I don't like cyano because that could accumulate, in my opinion, maybe, so I would avoid it. And that's basically it.
That was terrific. Dr. Rogers, thank you.
Thanks.
Great stuff. I love the incidentalloma. That's a term. Did you coin that yourself?
No. I didn't coin it, but man, we see them real often.
I mean, it's like the upsell or something in medicine. You can always get an extra, shake an extra 10 grand out of somebody with the incidentalloma. And that I always love the artwork that you have. Where do you come up with this stuff? That bird's eye view? That adds so much. I love those little pictures you put in there.
Yeah, I love the paintings. It's sort of like when I was younger, I wanted to write a couple of books, medical books, but I didn't know how to draw myself. And I really regretted not knowing how to draw. I tried to go back and learn how to draw, but I was so busy I couldn't do it. So it was sort of like a lifelong regret. And I love art. So what's happened is I always find myself looking at art books and studying art. And so I have a lot of paintings in my mind. So when I see a metaphor that resonates with a painting, I just put the painting in the picture.
Yeah, it just adds so much. It just fills it out a lot of ways. I almost forgot. Dr. Rogers' new book, Medical Reformation, Vegan Renaissance Bible. Go to Amazon. I'm putting a link down below. Check it out. You'll love it. Anyhow, thank you so much. I look forward to having you back for more great discussions in the future, Peter. I want to thank everybody for tuning in and for watching. Don't forget to like, comment, and subscribe. Until the next time, stay healthy.